Okay. And the role of the HMD or the designee, as I said, you have to keep this in mind. Those of you who end up professionally doing at least part-time hospice work, this is under very intense scrutiny now, and it's going to get only worse. There are things that you will do as an HMD or as a designee of an HMD that are intended by law to be covered by the per diem. Hospice should be paying you a salary for that under the per diem, right? So if you attend an IDT, hospice might pay you $600 to attend an IDT. Or they might say for the whole year of IDTs, we'll give you $10,000 or $20,000. That's your salary. We're paying, that salary is coming from our per diem because that per diem is covering that piece of your work. But that per diem doesn't cover you going to see a patient and offering a treatment for dyspnea or evaluating a patient for some other symptom. Okay? Family meetings are covered. Okay. So what's the economics of hospice? It should be pretty clear now. This is like any other managed care organization. The problem is that hospices are notorious for not managing care. Actually, it's sort of interesting because in New York State, managed care took over the healthcare system in New York State like it did in many other parts of the country, but managed care in New York State basically became discounted fee-for-service because the managed care companies never really managed care. And then the managed care companies began to insist on lots of pre-authorizations. And they, by and large, did not manage care. They just put in a barrier to try to reduce utilization. So managed care companies, at least in New York, have become discounted fee-for-service associated with a barrier to care. That's why we hate them. They're not actually managing the care. The goal of managed care organizations is to manage the care, to apply evidence-based medicine, best practices, and to try to get doctors to do best practice in an effort to reduce inappropriate use of expensive therapies. Managed care agencies do not manage care. Hospices are notorious for not managing care. And that's unfortunately what happens. Hospice agencies will tend to pay for whatever, or they set up these rules like no curative therapy, and that applies to anything that affects the disease. So the economics of hospice are dicey because you get paid one of the four per diems. 80% of the per diems are routine home care payment, and you have to pay the salaries of nurses, social workers, pastoral care providers, volunteer coordinators. You have to pay per diem or contract out to get dietary support, PT, OT. Home health aid services are required to be paid for. A piece of the physician's salary, a piece of the physician's time has to be paid for. You have to pay, if you have a contract with a facility like a hospital, you have to be able to pay for that, and hopefully you won't break the bank by doing that. So hospices have difficulty breaking even unless, as I said before, you figure out that there are risk pool manipulation or risk pool management. By risk pool, we mean what? We mean it's a full risk benefit. So if you get paid for a person who doesn't require a lot of services, you make money. If you get paid for a patient who requires a lot of services, you lose money. Most of the money is spent when a hospice program first sets up care. And so if you have long lengths of stay patients who don't require a lot of care, you make money. Where do those patients live? Nursing homes. So hospices that make money tend to be hospices with large census and a high proportion of the census in nursing homes. And that can be very profitable. And the problem, of course, is when that becomes unjustified. Unjustified because they're not providing effort. They don't provide any effort to get patients out of the community, or they keep people on the program longer than eligibility would determine. And that's what the government is up in arms about. And for physicians, the economics of most people who are palliative medicine specialists involve a contract with hospice that allows you to be an employed physician. As an employed physician, you may or may not get a salary for attendance at an IDT and other administrative functions. I personally think you should. If you ever email me in the future and say they're not paying me, I will tell them to pay you. That's what the per diem is there for. They have to pay you. They can have either a per diem relationship or a salary relationship. And in addition to that, that provides you with access to Bill Part A by seeing patients for billable medical services. Okay. Now, what's the length of stay in hospice nationally? What's the median length of stay in hospice?
17 days.
Not as bad as 2 weeks. It's 21 days. It's between 19 and 21 days, and it's been that way since the 80s. What proportion of patients in hospice are dead within 7 days of admission to hospice? 7? No, it's not that bad. About 25%. So, and remember, when you talk about hospice, it's admission and discharge, right? It's a completely different system of care. So it's admission and discharge. So in the United States, hospice, the hospice benefit and hospice services are severely underutilized, even relative to how they were envisioned by the people who set them up in the 80s. Right? It was set up as a quote-unquote 6-month benefit, acknowledging that physicians couldn't prognosticate, but figuring if they said 6 months, physicians would more or less get it right. They basically figured that the median would be about 4 months, and there would be some people on longer than 6 months and some people on shorter than 6 months, and that's what the people who set up the benefit thought. And instead, what happened was a median length of stay of 21 days that hasn't changed in 2.5 decades. And 25% of patients get admitted and they're dead within 7 days. So the way that the benefit was envisioned has not played out in that respect. And the rationale for that, the reasons for that, there's no rationale, but the reasons for that probably relate to physicians not understanding the benefit, the stigma associated with the linkage between death and dying, the curative issue, the fact that medical care is expensive, and small hospice programs have had to essentially close the doors to any patient getting disease-modifying therapy using the excuse that it's curative, even though it's not curative, but they say it's outside of our ability to take you because you're getting curative therapy. When you give up curative therapy, you can come in. Telling an American that they have to give up something to cure them, telling anybody, is first of all not good communication, right? Because you're telling patients, you're using words that people understand in a different way than they can possibly actually mean. So it's not fair to the patient to say, when you give up curative therapy, you can come in. Well, patients hear the word curative, and that's not what's happening. But that's the way hospice programs largely work. So because hospice programs have closed the door, physicians have not had the discussion with patients about these services to provide comprehensive care. Because physicians misunderstand what the nature of the benefit is, and they think it's a place you go to die as opposed to a comprehensive home care program. And because of the link with death and dying, which makes people in the United States nervous, you have a benefit that's profoundly underused. And that's really part of the specialty of palliative care and palliative medicine. It is to try to use the benefit more effectively without violating the rules of the road. Compliance is a key goal, right? You have to be compliant with the regulations. There's no wiggle room on that. Medical directors and case managers are sometimes worried that they're being pushed to bring people onto a program or into a hospital setting when they can't document that it's the right thing to do based on the regs. Frankly, if an agency does that, the professionals involved should think about leaving. The good agencies will never do that. Will never do that. And I can tell you from working in our agency, Metropolitan Jewish, or MJHS, Hospice and Palliative Care, since June, that's been my requirement, that you don't sign your name unless you're comfortable signing it. And there's total support at every level within the organization for that. So the bottom line is that we have to be in compliance, but that doesn't mean we have to support the underuse of the benefit. So we have to try to change the culture of care. Okay, so what questions do you have? What comments do you have? Yeah, Rishi.
Question. In terms of the levels of care where you said routine home care is 80%, GMP is 20%, does that refer to the whole census of the hospice average, right?
Yes.
Okay.
It's a 1 year United States of hospice care. 20%
Yeah. It's not patients, it's
Right.
days.
It's not patients.
It's not patients, it's days.
Because,
So if you have 100 patients in for a year, that's 100 times 365, which is whatever that is.
right.
No more than 20% of those days can be GIP.
Right.
And if they are more than GIP, the agency has to pay back the government.
So the small hospice programs are also at another disadvantage if they have obviously a lot of our patient populations they like the benefits, they come they have short stays and I think they utilize, probably proportionally a lot of the GIP is about 20%. So it seems like the small home hospices would also tend to shy away from many of those patients also because of their census is small. So I'm just trying to think in a community setting, would that necessarily be true?
I think it's an interesting thing to think about. I haven't heard that. The question was, since the actively dying patient, even in hospice programs, are more often in the inpatient unit getting GIP. If the lengths of stay are very short in large numbers of patients, you may get above the 20% of days being GIP. And I guess it's a risk, but I haven't heard that as being an issue.
It is underused in the United States, and currently entire United States, if you look at the GIP days under hospice, it's almost like 8%.
Right. Yeah, we're high in New York, and in fact we're high in MJHS, which is one of the reasons that we get probed. There are so-called filters that the fiscal intermediary uses to decide on probing, and when we were continuum hospice care, and even now, there's a concern. With continuum hospice care, it wasn't a concern; it was a reality. We actually got probed for compliance solely on the basis of the proportion of patients who were inpatient, because we were above 10%. And so, it is what it is. In New York, given the environment out there, there's going to be more GIP. Yes.
What qualifies somebody for the continuous care level as opposed to the regular?
Well, the question is what qualifies somebody for continuous care. So it's just a clinical judgment that somebody's needed 24/7. It's typically in the active dying situation. That's one of the, continuous care, Rishi, is used a lot more in other hospice agencies to keep people at home, to allow home death. So that's one of the ways you keep the GIP level down.
And I missed the part, how many days or what percentage or...
Can be continuous care. That I don't know. Does anybody know that?
In the past, if you're a hospice medical director, you would be told that we can provide continuous level of care in the final couple of days of life to make sure patient is responsible. But now, when the metropolitan jurisdiction, some big hospice programs may allow you to provide it up to a week.
Yeah, we've actually provided it for more than a week in a case-by-case basis. So I don't think that the regulations stipulate how long, but we'll look that up. It's another one for the Google machine.
So that doesn't apply to the 80/20, that's just a separate data?
Yes, that's not 80/20. The 20% only applies to GIP level care,
So you
not
can
continuous
have
care.
LPN at home to give sleep injections.
Okay, so let's go admit patients to hospice.